Welcome everyone, and for this week's episode of Webisode, we have chosen intrahepatic cholangiocarcinoma as the topic of discussion today. And I think I have one of my senior and dearest friend, Dr. Abhishek Yadav, who is from down south. He's from Lakeshore. He heads the Department of Liver Transplant there. And he'll be delivering the guest lecture today, and which will be followed by our regular panel discussion. So we have 4 different experts in this panel today. The surgical part will be covered by Dr. Abhishek. We have Dr. Gagan Saini, who is a very dear friend of mine, and he's a colleague. He is a maverick radiation oncologist in Max PPG. He's with us. Then we have Dr. Raajit Chanana, who is again a very dear friend, and he is a senior medical oncologist at Dharamshila Narayana Super Speciality Hospital in Delhi. And we have Dr. Sagar Tyagi, again a very competent intervention radiologist who is again our colleague at Max Parparganj. So this is the panel who's going to discuss, and I would hand over the session to Dr. Abhishek for his talk on surgery for intrahepatic cholangiocarcinoma. Dr. Abhishek, please.
Yeah, can I start sharing my screen now?
Yes, please.
Is it visible? Am I audible?
Clear, and it's visible. Yeah.
Great. So good evening, everyone.
On the slideshow mode.
Yeah, slideshow mode, please.
Yes, got it. Yeah. So good evening, everyone. Hello. And at the onset, thank you, Asit, for giving me a chance to speak. I think in this era of webinars, it's very difficult to choose that which one do you want to talk on, which one do you want to skip. So, but I think Asit is doing a great job, and you guys have. I keep seeing your programs, so I think it's quite impressive the work that you guys are doing. So, like I've been given the topic of intrahepatic cholangiocarcinoma. So it's not just the surgery. I'm going to cover a little bit about the diagnosis, because that's always a diagnostic dilemma that I would really dealing with hepatocellular carcinoma, cholangiocarcinoma. That differentiation is important before we straight away jump to the management of intrahepatic cholangiocarcinomas. Now, intrahepatic cholangiocarcinoma is quite a rare diagnosis, and it is though it is the second most common primary tumor of the liver, but overall population incidence wise, is still considered a rare diagnosis. Now, the reason behind that, why it was considered a rare diagnosis, was that there was really no definition of what is intrahepatic cholangiocarcinoma, what is extrahepatic cholangiocarcinoma, what is hilar cholangiocarcinoma. This differentiation has only come up in the 7th edition of the AJCC, when they finally said that intrahepatic cholangiocarcinoma is something that arises above the 2nd order biliary confluence. So I think after that differentiation has come, that really intrahepatic cholangiocarcinoma has become a entity in itself. Before that, most of these cases were kind of clustered together with hilar cholangiocarcinoma. So now we have a clear diagnosis, and intrahepatic cholangiocarcinoma accounts for about 20% of the total biliary cholangiocarcinomas that we see. Now, like I said, that these are the various headlines under which I'm going to be covering my topic. Like, first of all, I'm going to be talking about the rising incidence and what is the association with chronic liver disease of intrahepatic cholangiocarcinoma. Then, like I said, that differentiation from HCC is of paramount importance, because most of the times we always have that confusion. Then management, the role of surgery, the role of liver transplantation, and a little bit about just a couple of slides about the role of local regional therapy in management of these cancers. Now, this is a slide from the SEER database from the United States, which the blue line is the one which denotes the incidence of intrahepatic cholangiocarcinoma, and you can see that it is going up. Now, there are many reasons given behind this increasing incidence of intrahepatic cholangiocarcinoma. Some people say just that we are imaging more patients, imaging has become more sophisticated, and hence it is the incidence is rising. Of course, now we have a clear definition of what is intrahepatic, what is hilar, and therefore we can classify our tumors into their respective subgroups. Also, but those reasons are not enough to explain this rising incidence, especially in the West, because till a few decades back, intrahepatic cholangiocarcinoma was considered a diagnosis of the East, primarily related to the liver flukes, hepatolithiasis, etc. But this rising incidence in the West has made people ponder that, that what exactly is the reason behind this rising incidence. And this slide will probably show a little, throw a little light on this rising incidence. We all know about the standard risk factors for intrahepatic cholangiocarcinoma, like liver cysts or hepatolithiasis or fluke infestation. However, not too many people talk about the fact that the same risk factors that are responsible for the occurrence of hepatocellular carcinoma, the same risk factors also apply for intrahepatic cholangiocarcinoma. So you can see the various risk factors. Just a sec. The same risk factors that are there for the hepatocellular carcinoma, the obesity, hepatitis B, C, etc., are also relevant in the causation of intrahepatic cholangiocarcinoma. So the rising in incidence of these risk factors could also explain a rise in the incidence of this particular tumor. Another interesting fact, like we all know that intrahepatic cholangiocarcinoma is primarily related to any kind of inflammation or irritation that is happening inside the biliary tree. There is also now evidence to show that hepatitis B is a risk factor, not just for hepatocellular carcinoma, but also for intrahepatic cholangiocarcinoma. And like hepatocellular carcinoma, even non-cirrhotic patients who are hepatitis B carriers are risk for developing intrahepatic cholangiocarcinoma. Now, what are the variants? Basically, we have three variants according to the Japanese classification. The most common being the mass-forming type, which is the garden variety seen in about 70% of intrahepatic cholangiocarcinoma. Then we have the periductal infiltrating type, which is the second most common. And then we have the rare type of the intraductal growing type. Now, I'm going to just dwell a little bit upon the histology of these various tumors. Now, the reason behind me going into the histology is that once we know the histology, especially when it comes to liver tumors, it's very easy to decipher the imaging characteristics of that particular tumor. So if we talk about the histology of the mass-forming type of intrahepatic cholangiocarcinoma, they generally present as a peripheral tumors, which grow quite large in size, primarily basically because these patients are generally asymptomatic. Now, what is important to note is that unlike hepatocellular carcinoma, these tumors have a large stromal component. This figure that you can see that the inside stroma component, which is generally non-viable and fibrous tissue, makes a large chunk of these tumors. And the periphery, you can see that the pink tumor, that the pink part is the viable part of the tumor, which is constituted by the rapidly multiplying cells. Another characteristic feature of these tumors is that they tend to infiltrate the portal veins, and that is one explanation for the satellite nodules that generally we encounter when we see these mass-forming cholangiocarcinomas. Another differentiating factor from hepatocellular carcinoma is that although they invade the portal pedicles and the portal vein, but yet they do not cause thrombosis, unlike the hepatocellular carcinoma types. Then the second common variant is the periductal infiltrating type. Now this is the homologue of the hilar cholangiocarcinoma. Histologically, it is quite similar to the mass-forming variant, just that the difference being that this tumor generally grows along the biliary, along the peripheral bile ducts. Another differentiating factor from the mass-forming variant is that these tumors are more vascular than the mass-forming variant, and we are going to talk about that again when we talk about the radiology of these tumors. And this vascularity is primarily derived from the biliary tree, and thus making these tumors more vascular than the mass-forming variants. The rarest type is the intraductal variant, which is considered to be the homologue of the IPMN of the pancreas or the biliary tree. This tumor generally presents as a gross and abnormal dilatation of the biliary tree, which is generally filled with mucin, quite similar to the IPMN variants that we see in the pancreas. And sometimes they might have a small cellular component which might be pedunculated or sessile. Another variant, I think, which is more important from the clinical point of view, however, this is not talked about in the Japanese classification, is the mixed hepatocellular cholangiocarcinoma variant. Now, again, there are a lot of hypotheses against explaining that how a hepatocellular variant can transform into a cholangiocarcinoma variant, thus making it more aggressive. So, without getting into the debate, this combined hepatocellular and cholangiocarcinoma accounts for about different series talk about between 1% to 10% of the total incidence of intrahepatic cholangiocarcinomas. And again, we will talk about this tumor a little later in our series. Very important slide is the correlation of the different variants along with their histology. Now, how do we interpret intrahepatic cholangiocarcinoma? Basically, intrahepatic cholangiocarcinoma on imaging will appear when you give contrast. They generally will have a good peripheral rim enhancement, and there will be centripetal filling up of that contrast in the second and the third phase of imaging. Now, the reason I've already talked about, since only the periphery of this tumor contains viable tumor cells, so that's why they enhance early on in the phase, and the center, which is predominantly constituted by stroma, generally fills up later on in the later phases of the imaging cycle. Periductal variant, like I said, it is more vascular as compared to the mass forming variant, so therefore the vascularity will be more pronounced in this tumor, and these tumors, like I said, generally will follow the pattern of the biliary tree, and thus making it quite characteristics. The intraductal variant will quite rare. So again, this will present as almost like a non-enhancing ecstatically dilated duct, and might have some viable tumor component inside the cell. So that's about the histology. Another important fact, like I said in the beginning, that the main problem that we always encounter when trying to come to algorithm to manage these tumors is to differentiate it from hepatocellular carcinoma. Especially more and more cirrhotic patients that we see, especially when it comes to the transplant setting, a lot of times we will have that debate. We find a lesion in the liver. Is it a cholangiocarcinoma? Is it a hepatocellular carcinoma? So I think that differentiation is quite important, and that is what foxes us clinicians most of the times. So a few differentiating fact between HCC and intrahepatic cholangiocarcinoma, and the reason behind them histologically. HCC, as we all know, derives its blood flow primarily from the arterial system, so they will have quite a arterial blush and a rapid washout for the same reason, while mass forming cholangiocarcinoma will generally have only a peripheral enhancement, good peripheral enhancement, and a rapid and a slow centripetal filling in the contrast phase. What about fat? HCC characteristic contains fat, so any MRI sequence will clearly differentiate between these about the presence or the absence of fat inside the tumor. What about the capsule? Intrahepatic cholangiocarcinoma characteristics do not have a capsule, versus a hepatocellular carcinoma, which most of the times you will find an enhancing capsule around these lesions. When we talk about diffusion restriction on the MRI, again, for the same reason that hepatocellular carcinoma is a more vascular and a more cellular tumor, so therefore the diffusion restriction will be more enhanced in hepatocellular carcinoma versus in a cholangiocarcinoma, where it will be less pronounced. Unfortunately, this differentiation is not always black and white, and most of the times we will see these tumors labeled in shades of gray, where there will be some characteristic favoring one tumor or the other. So for that particular reason, we all know, we are all aware of the Lirard's scoring system, and that is where it really comes in handy. And I'm not going to talk about the details of the Lirard system, but whenever we see a cirrhotic patient with a radiological finding of a LR4 or a LRM is a new classification that means a liver tumor which is most likely a malignancy, however it cannot be differentiated whether it's a cholangio or a HCC. So LR4 is a suspicious of HCC, and a LRM is a malignant tumor. So these are two conditions wherever we see patients coming with any of these classifications that we would always press for a biopsy from these lesions before we progress on to making a therapeutic decision for these tumors. What about the role of PET scan? Fortunately, these bad tumors are all PET avid, and most of the times they will be avid to the PET tracer uptake, and it's almost 100% sensitivity that we can get for these tumors. Now, in addition to the metastatic workup, PET-CT also has two additional benefits when we talk about intrahepatic cholangiocarcinoma. First is that another major differential diagnosis of hepatocellular carcinoma is always a metastatic lesion to the liver, metastatic tumors to the liver. So doing a PET-CT kind of excludes the diagnosis of a metastatic deposits in the liver. And also PET-CT also has a high sensitivity for regional lymph node detection in intrahepatic cholangiocarcinoma. And the presence or absence of lymph nodes does have a huge prognostic implication in intrahepatic cholangiocarcinoma, as I'm going to discuss in the latter part of my talk. So now, since we've made the diagnosis, finally we are moving to the management part of these tumors. Unfortunately, only about 15% of these tumors are resectable when they are first seen, and surgery with an R0 resection is probably the only validated treatment modality for these kind of tumors. The role of ablation and neoadjuvant therapy is quite limited at this point, and transplantation, which we are going to talk about later, the role of which is still evolving. Principles of surgery, when we are talking about resection for intrahepatic cholangiocarcinoma, nothing very dissimilar to the same principles that we follow for resection of any other liver tumor. You have to make sure that you're doing R0 resection, because that is the only thing which is of proven benefit, and leaving behind a 30% healthy or a 40% diseased liver remnant with adequate inflow, outflow, etc. The augmentation techniques, portal vein embolization, etc., are used according to the standard indication. So there's nothing special to talk about that here. What about the role of staging laparoscopy? Yes, staging laparoscopy does have a definitive role before proceeding for surgery in these tumors, and about 30% of the patients can obviate a negative laparotomy if a staging laparoscopy is done. And of course, if you add ultrasound to your laparoscopic armamentarium, especially to pick up regional lymph nodes, that further increases the yield of these. Lymphadenectomy, again, the role of lymphadenectomy in various liver tumors is quite controversial and also confusing at the same time. If you talk about hepatocellular carcinoma, the garden variety hepatocellular carcinoma, there is no indication for doing a lymphadenectomy, whereas in fibrolamellar carcinoma, regional lymphadenectomy is advocated. Again, there is not too much evidence to show that lymphadenectomy has a therapeutic role in these tumors, but definitely lymph node metastasis is a marker of bad biology in these tumors. And certainly, if you do a lymph node clearance and you find positive lymph nodes, certainly you know that your patient is going to be a candidate for some kind of an adjuvant therapy, if it is available, or just to prognosticate the patient somehow. The number of lymph nodes that are to be harvested when treating these tumors is unclear, and there is no recommendation as to the number of lymph nodes that have to be cleared. Again, lymph node stations are N1 and N2 when we talk about intrahepatic cholangiocarcinoma. N1 is the regional lymph nodes, the hilar, the hepatic artery, the retropancreatic, etc. And the regional and the distant lymph nodes, which are considered as N2 disease, are the celiac and the superior mesenteric. So any N2 lymph node disease remains a contraindication for resection in these tumors. Now, what about the results of resection? Unfortunately, the results of resection are not as great as we see in hepatocellular carcinoma, and at the best, people have reported 35 to 40% 5-year recurrence free survival. Interesting to note is that most of the recurrences that generally happen in the first 2 years, 2 years after resection. And that said, there is of course a subset of patients with good risk factors who can have a can have a good survival rate, recurrence-free survival rate, which is almost as comparable to the hepatocellular varieties. And what are those prognostic markers? There are many of them: the tumor markers, lymph node metastasis, vascular invasion, etc., etc. However, the two most important parameters that guide the prognosis of these tumors are lymph node metastasis and the number of tumors that we encounter. Now, having talked about the bad biology of the tumors, the second question that obviously comes is what is the role of adjuvant therapy? Unfortunately, the role of adjuvant therapy in these tumors is all extrapolated from cholangiocarcinoma, which are at other sites. They can be lower bile duct cholangiocarcinomas, pancreatic or hilar cholangiocarcinomas. There's very little data specifically for intrahepatic cholangiocarcinoma to suggest it as a standard recommendation. What is recommended is that gemcitabine plus 5-FU or 5-FU based radiation to be definitely used in patients with a positive margin resection or lymph nodes. Now, again, when we talk about positive margin in liver, it is a little different from positive margin, say in pancreas or rectum, because those of us who do liver surgery, we all know that once we cut the liver, the resection margin is so huge and so vast that it is very difficult to pinpoint which margin was positive. And and we know that the liver is a three-dimensional organ. So although we find in the literature that yes, positive resection margin, you should give postoperative radiation, etc. But practically, I find it quite difficult that how can you pinpoint a positive margin in a liver when you have such a huge cut surface there. Again, the role of adjuvant therapy in the setting of an R0 resection remains unclear, and ongoing trials, maybe in the future we will have an answer that even after R0 resection, should adjuvant therapy be given to try and prolong the survival of these patients with these bad tumors. Now, what about the role of liver transplantation? Yes, all of us transplant surgeons do love to talk about liver transplantation, and sometimes people do accuse us of bringing in transplant into every malady that affects the liver. Especially people have this impression that, oh, cholangiocarcinoma is such a bad disease, and look at these people, they're talking about transplantation in such a horrible cancer. I would not say that the results of transplantation are that dismal. So basically, there are two scenarios that we have to talk about here when we talk about the role of liver transplantation in cholangiocarcinoma. The first scenario is the more common of them, which we all encounter in our daily practice, is that you have a pre-op diagnosis of a cirrhotic patient with an HCC. You have a LR4 lesion or something, or inconclusive lesion, which you have a reasonable doubt to think that this is a HCC. You do a transplant for that patient, and postoperative, the explant biopsy shows that it is either a cholangiocarcinoma or a mixed variant. So that is a scenario that we encounter more frequently. So I'll be talking about that. What is the evidence to support and what should be the protocol of managing these patients. And then second, I will be talking about whatever limited evidence there is to show that how can some of these unresectable tumors, can they be really downstaged and brought to transplantation like the Mayo protocol, etc. have been doing for hilar cholangiocarcinomas. So talking about the first scenario, which is the more common scenario, which is the unintended transplant done for intrahepatic cholangiocarcinoma. Across literature, if you see that about 1 to 3% of transplants that are done for hepatocellular carcinoma, in fact, the explant biopsy does show some component of intrahepatic cholangiocarcinoma. The diagnosis of these tumors is already not simple, and if these patients come to you after downstaging, after a TACE or a tear, then this differentiation becomes even more difficult. And because it's such a heterogeneous group, so that is the reason why different series have shown different variables. And this is one recently published series. I think it is a no, it's not a multi. It's from a single center. And in these graphs, if you see that the green and the black lines denote the intrahepatic cholangiocarcinomas, and the blue and the red ones show transplantation done for hepatocellular carcinoma. So as expected, the survival, the recurrence and the survival rates for intrahepatic cholangiocarcinoma, obviously, there is no doubt that the survival rates are inferior to transplants done for hepatocellular carcinoma. However, point to be noted is that still, in spite of bad results, people have still shown 1 and 5 year survival rates of 80% and 35%, 5-year survival rate of 35%, which is not too bad considering this bad tumor. And this is not just one series. There are other series also who have reported that 5-year survival in the range of 35 to 40% when transplanting for cholangiocarcinoma. Again, these data have to be taken with a pinch of salt, because we must understand that these are probably good biology tumors, and these tumors were in fact transplanted thinking that these were the hepatocellular carcinoma. So obviously their biology was a little different, probably better than the garden variety of intrahepatic cholangiocarcinoma. So really at this point, we cannot extrapolate this data and say, okay, oh, fine, we are getting a 40% 5-year survival, so why not do transplants for all intrahepatic cholangiocarcinoma? So now I think just moving on to the final 4 or 5 slides of my talk. What about the other scenario when you can in fact downstage some of these tumors, like people have tried for hilar cholangiocarcinomas and then try and do a transplant? So I think when I searched the literature, I just came across this one group, that is the UCLA group, who in fact have published their protocol of using new adjuvant therapy for unresectable intrahepatic cholangiocarcinomas and then transplanting them. So they have a protocol where they give upfront new adjuvant therapy and radiation oblique transarterial therapies depending on the size of the tumor. I think what they do is that if it's a tumor less than 6 centimeters, they give EBRT. If the tumor size is more than 6 centimeters, they opt for TARE. And then after neoadjuvant therapy, they reevaluate their patients and they have a risk prognosticating factor. So only if these patients fall under low risk category, then they only in those patients have they found a really a reasonable survival rate when they've done transplants for these patients. So in fact, they've shown that in low risk patients, when you downstage and do transplants, you can get almost a 75% 5-year survival rate, versus a very dismal survival rate when you transplant cholangiocarcinomas with high risk factors. So ultimately, it all turns out to the tumor biology, and what we practically also do is that when there's a diagnostic doubt about intrahepatic cholangiocarcinoma versus HCC, what we generally do is that we give these patients upfront downstaging therapies. Then we wait on these patients, we see how they are behaving, and only then do we proceed for something as radical as transplantation for these patients. What has our experience been over the last 5 years? Out of the 35 odd transplants that we've done for hepatocellular carcinoma, we've had 3 patients who have had some form of cholangiocarcinoma in the explant. Either it's a mixed cholangiocarcinoma. I think most of these patients have been mixed hepatocellular cholangiocarcinoma patients. All these 3 patients were within Milan criteria, either de novo or they were downstaged to the Milan criteria. And like I said, that most of these biopsies had shown a mixed intrahepatic and a hepatocellular carcinoma. We don't have a very long follow-up. The median follow-up of these 3 patients is 23 months, and to date, we do not have any recurrence in any of these 3 patients. Though I must add that when we do transplants for hepatocellular carcinoma versus when we do a transplant for cholangiocarcinoma, of course, our post-operative surveillance is more stringent. In hepatocellular carcinoma, we generally do serial scans or tumor markers every 6 months. Versus in this subset of tumors, our frequency is 3 monthly in the first year, and after the first year, if they remain recurrence free, only then do we increase our duration of surveillance in these patients. Lastly, what about the role of local regional therapies, intra-arterial therapies, steer, hepatic artery infusion, etc. Now, there is a reason why these cholangiocarcinomas do not respond as well to local regional therapies as compared to HCC. And going back to histology, because these tumors are less vascular, they are less dependent on the arterial flow. So therefore, logically, they have to be less responsive to intra-arterial therapies. And however, a small subset of patients does respond well. And this is again a publication which shows that that there is some survival advantage in trying local regional therapies for these patients, especially, and these are all unresectable patients whom we don't have anything better to offer. So definitely, as compared to doing nothing, these patients being subjected to intra-arterial, some kind of intra-arterial therapy, they can have a survival advantage. What is interesting and encouraging is the blue line here, which shows that the patients who in fact have a good response to these regional therapies, they in fact can have a good survival rate in this unresectable tumors who would otherwise be just subjected to the best supportive care. So I think coming to the end, just what are my take-home messages from this talk? Intrahepatic cholangiocarcinoma is a rare aggressive disease, and the incidence is rising because of the reasons that I talked about. Preoperative differentiation, I think, is of paramount importance, and that is something that we surgeons are always concerned about, especially when we are subjecting these patients to something as radical as transplantation. Surgery forms the mainstay. However, surgery is unfortunately is possible only in a small subgroup of these patients. The role of neoadjuvant therapy, I think, if there are oncologists in the panel, they can probably throw more light if there is what is the latest update on is there really a magical chemotherapy that's around the corner that can do something for these patients. Liver transplantation, yes, at this point, people are cynical, but what I feel is that definitely in the future, the growing the future of this tumor will probably come from the evolution of the field of transplant oncology, and like many other rare indications for transplantation, which have become quite commonly accepted. So maybe 10 years, 15 years down the line, we will see that intrahepatic cholangiocarcinoma would also become a standard indication for transplantation. But however, to this date, with the evidence available, I cannot propagate that to my patients. And when we subject our patients to something like this for a disease that we know little about, we always follow this aphorism called as caveat emptor, which means that let the buyer be aware of what they are getting into and let them be part of the decision making. So with that, I thank you very much for your patient listening, and any questions I would be happy to answer. Thank you.
Yeah, thank you, Dr. Abhishek, and it was a very wonderful and elaborate talk. But I must tell you, you have almost killed our panel discussion. I was supposed to discuss almost all the things that you have mentioned in your talk. Since you are a part of panel, I think we will take the questions as we go along. And any of our panelists who also wish to ask you anything, we can encourage them to have it, let them bring it on during the discussion part as well. We have some questions in the chat box. I think I will take it as we go along the panel, right? So I think I'll just share my screen and just let me know if it is visible to you guys.
Yeah, it is.
It is, right. So I put it on Twitter. Yeah. So this is the panel that we have today, and I think now we guys know what Dr. Abhishek does. He was, I think, unknown to most of us here, but now they know the mental that you have. So let me begin with what you have already mentioned, that intrahepatic cholangiocarcinoma, it is the second most common primary liver tumor. Though it is the common, it is still a rare entity. It constitutes only 20% of all cholangiocarcinomas. surgery thus far remains the only potentially curative treatment option. And I say surgery, I would include both resection and transplant in this. But having said that, the biggest challenge is here. Recurrence rates, even after curative, so-called curative resections, is to the tune of 50 to 80%. And this is what the Achilles heel of this surgery is. So anyways, resectability rate is very low. We can only resect up to 15% of these intrahepatic cholangiocarcinomas. And when we do resect, they come back, and they come back pretty fast. So what can we do about it? So most of the things that Dr. Abhishek have just dealt with is how does one make a diagnosis of intrahepatic cholangiocarcinoma? One, because it is rare. Secondly, it is very easy to confuse it with other commoner malignancies, likely HCC and the Mets from extrahepatic sites. So what are the good MR and CT findings? Though Abhishek has dealt with them in his talk, I would ask Sagar. He is a wonderful, amazing radiologist. He will just guide us through and make us even wiser. And especially, how do we differentiate it from other two important pathologies, that is HCC and metastasis? Sagar, if you can just help us with that. So
yes, hi everybody. Yeah, I'll
ask you to share the.
Yeah, I'll share my screen.
Right.
Now, is it visible to all?
Yeah, it is.
Okay. So just briefly, I'll start with a brief introduction. Like on the basis of macroscopic tumor growth pattern, ICC are divided into three types. First is the mass forming, second periductal infiltrating type, and intraductal growing type. Mass forming is basically involving the intrahepatic small bile ducts, and both of them involve intrahepatic large bile ducts. So what we do in radiological point of view is we need a pre-contrast scan and a post-contrast scan here. Post-contrast, we take three phases basically: arterial phase, portal venous phase, and a late delayed phase. As Dr. Abhishek has told, this is not a very vascular tumor, so the arterial phase images should be taken in late arterial phase, that is approximately up to 30 seconds later. In HCC, we take these images at 15 seconds. The portal venous phase is the same at 60 seconds, and the delayed phase is almost the same as HCC, that is at 180 seconds. So I'll now discuss the radiological points of mass forming ICC. This lesion is basically hypoattenuating on CT scan images. It is a lobulated mass lesion with central necrotic or fibrotic changes. Fibrosis and necrosis are varied in different patients. We see a ductal dilatation peripherally. These, as Dr. Abhishek has already told, this lesion basically invades the adjacent portal vein branches and is responsible for the multicentricity of the lesion. On arterial phase, as the viable tumor cells are at the periphery, we see an irregular peripheral enhancement in the arterial phase with gradual centripetal enhancement because of the fibrous tissue in the portal venous and the delayed phase. Vascular encasement is a characteristic finding in ICC, but intravascular tumor thrombosis is very, very rare as compared to what we see in HCC. Tumor thrombus is common in HCC, not very much common in the ICC. It causes obliteration of the portal vein, which is responsible for atrophy of the involved segment and also the capsular retraction. On diffusion-weighted images, there is a typical target sign which we see on the cholangiocarcinoma. That is basically again due to the reason that the viable tumor cells are present at the periphery. So this target sign on diffusion-weighted images is not seen in HCC. This is very typical of ICC.
Right. So
yeah. Yes.
No, go on, Sagar. Go on.
Okay. So these are the basically CT images. This first image is the arterial phase image. You see a very subtle peripheral-like enhancement in the arterial phase images. Next image, you see a portal venous phase image in which you can see a subtle increase in the centripetal enhancement Also, you can note this black arrow is the capsular retraction and the satellite nodule, which is due to the invasion of the portal venous channels. In the third, the C image, you can see the encasement of the portal vein branches, but there is no visible tumor thrombus. Now coming on to the MRI images, this is first A is the T2 weighted images, which show a subtly hyper-intense lesion on the T2 weighted axial images. Again, we can see in the arterial and portal venous phase the centripetal filling of the tumor. Most common differential, as Dr. Abhishek has already told us, is the HCC. I'll tell the points in detail. Few differential can also be like we have to differentiate hemangioma, which is a characteristic puddling enhancement. In the first image, you see it is an irregular puddling type of enhancement. In ICC, we see a regular type of enhancement. It is peripheral although, but it is irregular. It is not irregular, or a vesical puddling sign is not there. How do we differentiate it from hepatic mets? Hepatic mets is mostly has a central necrosis. So on T2 weighted images, there will be a bright spot in the center and not very bright spot in the periphery, which is comparable to that of ICC. But how do we differentiate hepatic mets from ICC is again from diffusion weighted imaging. The target sign of diffusion weighted imaging is very, very characteristic of ICC. Organizing abscess with stone disease also can mimic ICC, mass forming ICC, but organizing abscess and hepatic tuberculous abscess gives a typical of multi-layered appearance on the CT images. In the arterial phase, you can see this characteristic 4-layer appearance of hepatic tuberculosis. All these layers are, the first layer is due to the hepatic parenchyma enhancement, second layer is because of fibrous tissue, the third layer is because of the granulation tissue, and the central part, again, which is not enhancing, is the necrotic tissue. Lastly, how to differentiate it with hepatocellular carcinoma, Dr. Abhishek has already shown this slide. In arterial phase, hepatocellular carcinoma shows a characteristic arterial phase hyperenhancement with portal washout. As ICC is not doesn't have a main feeder from hepatic artery, it shows just a subtle rim-like enhancement with progressive centripetal enhancement. HCC shows typical intralesional microscopic or macroscopic fat, which can be picked up by any of the MR images. Coming on to capsule, HCC shows enhancing capsule enhancement, which is not seen in ICC. Lastly, diffusion weighted imaging target like hyperintensity is seen because of the viable tumor cells at the periphery. This is very, very typical of ICC, which can be easily differentiated from HCC. Now, few things about the periductal and intraductal variants of ICC. Periductal variants basically extends longitudinally along the bile ducts and cause a wall thickening, which can be seen as wall enhancement on arterial and portal venous phase. Ultimately, it causes luminous stenosis and causes proximal biliary dilatation. Differential of the periductal infiltrating type of ICC are basically IG4 related sclerosing cholangitis. In periductal infiltrating ICC, what we see is a eccentric wall thickening, but in IG4 related sclerosing cholangitis, we see a circumferential wall thickening, which is mild in nature. Like the cutoff value for the wall thickening is 3 mm. If it is less than 3 mm and if it is circumferential, it goes more in favor of IG4 related cholangitis. If it is irregular, eccentric type of wall thickening and more than 3 mm, it goes more in favor of periductal ICC. How to differentiate it from a benign stricture? Longer segment of stricture, thicker involvement, again eccentric or asymmetrical involvement, and irregular luminal narrowing suggests a periductal infiltrating type of ICC. Lastly, if there is diffuse involvement of the bile ducts, one of the DD can also be periportal lymphadenectomy metastasis.
Right. Thank you, Sagar, for such a wonderful elaboration. So just tell me one thing. So what should be the primary modality? Should it be a CT or should it be a contrast enhanced MRI with diffusion restriction? What would you suggest for a clinician that he should ask for if he has to differentiate between various
triple phase CT is enough, I guess.
But what I make out of from your description is that by an MR, you are getting much more elaborate information, and also with the help of diffusion restriction, you can able to differentiate with various other etiologies. So
yes, sir. 2 points.
Should MR not be the primary modality that we should be looking for?
MR, if there is a confusion or overlapping HCC ICC variant, then we can go for MR to just to pick up microscopic fat, and advantage of diffusion restriction is obviously there.
Right. So I think, as a nutshell, can you say that MR will score over CT for making a good diagnosis in
few points? Yes.
Right. Okay. Right. Thank you so much. So I think I'll go back to my screen share and. No, I don't think this is. Is it visible to you guys?
Yeah.
No, this is. I'm sorry. I think I have to go on to something else. I think I messed up with my screen share. Just give me a sec, please. So, gosh. So meanwhile, can I, one of the important thing that we need to discuss is, after once we have made the diagnosis, is Abhishek, I'll come to you. Why do you need to differentiate between HCC and IHC? The treatment modalities are same. If it is resectable, you're going to resect it. If you think they are transplantable, you're going to transplant it. So why do you actually need to differentiate between an HCC and intrahepatic cholangiocarcinoma if the treatment is not going to differ?
I would guess the need for lymph node dissection will be higher in ICC. That is certainly one important reason.
Abhishek, your thoughts?
I think when you're contemplating resection, I would not really press for a biopsy, because anyways you're going to resect, and if you think that you can get R0 resection, that I would not really press for a biopsy. But that remains quite a rare situation that we encounter, that these tumors very rarely are they resectable. However, when it comes to transplantation, I would definitely want to be sure that you're not dealing with a cholangiocarcinoma, because the implications of transplant, the recurrence rate after transplant, etc., are much higher with intrahepatic cholangiocarcinoma versus HCC. So to just summarize that answer, I think resection, if you're sure that you're going to get R0 resection margins, then even if there's a confusion, straight away go and resect. Versus when you're going to transplant, then definitely I would want to biopsy if there is a doubt in the diagnosis.
I think I will.
But Dr. Abhishek, if it would be a small HCC, the ideal treatment would be transplant, right? OTP. So, I mean, would you, so if there is a patient with you whom you're not sure whether it's a small HCC or a small ICC, intrahepatic cholangiocarcinoma, would it not be prudent to know what it is? Because in a intrahepatic cholangio, your resection will actually, with lymph node dissection is what is needed. And in a small HCC, you would certainly tell them that, okay, the ideal treatment is transplant, but okay, fine, we can go for this as well.
No, I would not do that. A small peripheral HCC in a non-cirrhotic patient, or even in an early cirrhotic patient, I would not offer them transplant. I would probably just resect them anyways. So I mean, I'm talking about, I'm not getting into that controversy of transplant versus resection. But what I'm saying is that a tumor, if it is resectable in every sense, like there's no portal hypertension, there's no cirrhosis, the remnant is adequate, etc., whether it's a HCC or whether it's an intrahepatic cholangiocarcinoma, it would not make too much of a difference in that.
Boss, if the patient is potentially curable, don't you think we should, push for the ideal treatment? I mean, since we are talking science here, I mean, those are my thoughts. I think, since I'm not a surgeon, I will probably let another surgeon pursue these thoughts or not pursue them.
So, okay, let me chip in here a bit. So, the confusion usually arises in the setting of in a cirrhotic background. Most of the times, if it's a non-cirrhotic background and you have an IHC or a HCC, radiology most often than not will give us a clear diagnosis, and we are able to come to a conclusion prior to administering the treatment. In a non-cirrhotic patient, anyways, like Abhishek told you, that the treatment of choice in both the cases, if it is a resectable, would be resection anyways, right? So in that scenario, things won't matter much anyways. If it is a cirrhotic background, since the etiology could be same for both, and there are times when you have an atypical imaging features where we are not able to ascertain whether it's an HCC versus intrahepatic cholangiocarcinoma, this is possibly where we would resort to the biopsy. So I'm coming to that in a next slide here before we discuss PET scan. So what is the role of PET scan in these tumors? Dr. Abhishek, would you ask for a PET scan as a routine for any patients of intrahepatic cholangiocarcinoma whom you are contemplating surgery, or you do it on a case-to-case basis?
Well, I used to do it on a case-to-case basis, but after I went through the evidence that I gathered to make this presentation, I think it should be a standard of care. But unfortunately, I think this question remains a very hypothetical question, doing a PET-CT, because most of the times preoperative diagnosis, even if you're considering resection, is always, you will never, unless you do a biopsy, you will never really have a clear-cut diagnosis. And as long as you are quite sure about your resection, that it's going to be a safe resection, etc., and your tumor markers are fine, then no, I mean, I would not push for a PET-CT in every patient if the diagnosis is quite straightforward. If there is a doubt in the diagnosis, then maybe yes, in selected cases, yes.
Right. So when I said PET scan, I think we were considering more as a staging protocol rather than helping us to reach to a diagnosis.
Yeah, I think if I'm
yes,
sure about the diagnosis of
can,
intrahepatic cholangiocarcinoma, then definitely yes, PET-CT.
Yes. So what the point that you made is whether PET can help us clinch a diagnosis of HCC versus intrahepatic cholangiocarcinoma. Yes, it can help us to certain extent, because we know that HCCs are traditionally not very FDG PET avid versus intrahepatic cholangiocarcinoma, which are actually very avid on FDG PET. And the literature says that a PET scan do alter your treatment in almost 15 to 20% of cases. So it would be a nice idea to get a PET scan in case we are planning a resection anyways. Right. So again, here we come to a controversial topic, whether we should biopsy these lesions prior to treatment. And obviously, there is no doubt if it is a setting of, we are not considering a resectional procedure upfront. If it is a neoadjuvant treatment, I think there is no doubt about it that we have to get a histological diagnosis. If we have to get a palliative treatment in the sense of palliative chemotherapy or additional regional modalities, I think role of biopsy is well established. We have to get one. When do you need to establish a diagnosis? So I think when we are discussing about intrahepatic cholangiocarcinoma, most of these scenarios are usually hypothetical. Like you said, Abhishek, we hardly encounter intrahepatic cholangiocarcinoma in our clinical practice. I mean, we stumble upon these tumors once in about 2 months or 3 months, unlike HCCs, which we see almost on daily basis in our clinical practices. So yes, most of these scenarios will be hypothetical. But one of the most critical scenario would be underlying cirrhosis, and then you're not able to reach to a diagnosis. So in that scenario, I don't think you would say that doing a biopsy would do any harm to anybody. So what are your thoughts on getting a biopsy here? Raajit, when do you want a biopsy for your patient?
Yeah, hi. So obviously, if we are planning some form of systemic treatment, especially before surgery, so biopsy is a must for giving any form of systemic treatment. If you don't have a histological diagnosis, then we definitely need a biopsy to confirm the diagnosis. So for planning new adjuvant, which is not the standard of care, so the standard remains surgery if the disease is resectable. However, in some certain cases where we have a large tumor, which a surgeon is maybe somewhat confident that after a particular course of systemic chemo or chemoradiation that may be assessed for surgery. then we can plan new adjuvant treatment. So as of now, there is no data to support a new adjuvant treatment.
If you have radiologically, if you have intra-aortic nodes or a node posterior to pancreas, posterior superior pancreatic or duodenal node, Abhishek, would you want to have a US guided FNAC or biopsy to confirm the staging here? Would that be a role that you would want?
Yeah, definitely. There's no doubt about that. Any nodes away from the regional draining basin, definitely I would make a regular attempt to get a histological proof from that.
So does presence of regional lymph nodes lend support to one diagnosis over other? Sagar, there is a regional lymphadenopathy. Do you feel that goes in favor of intrahepatic cholangiocarcinoma versus HCC? Can you unmute yourself, Sagar?
I think there are many, if Sagar is not available, I think there are many variables there. I mean, hepatocellular carcinoma also, we all know that that after any, most of the patients we see are not de novo patients, especially patients who come after TACE, tear, any kind of local regional therapies, they will have lymph nodes, and that always confuses the picture. So even we know that fibrolamellar HCC can have regional lymphadenopathy. So although it can be a pointer, but I would not really clinch my diagnosis based on the presence or absence of lymph nodes on ICC versus HCC.
So why distinction is important here, Abhishek, is because if it's an HCC and if there are regional nodes, most of the people will deter from offering surgery or resectional procedures to these patients. Whereas for an intrahepatic cholangiocarcinoma with regional lymphadenopathy, you would happily go ahead and perform regional lymphadenectomy, which usually is not a case for HCC. So in such a scenario, would you want a biopsy to confirm the diagnosis prior to going in?
Yeah, but only in de novo HCC. If HCC has been previously tampered with, any kind of therapy has given TACE, tear, RFA, etc., then I would not rely on the lymph nodes because they always develop a regional lymphadenopathy after any kind of intervention. So, but in a de novo case, definitely yes.
Yeah, Dr. Gagan.
Dr. Asit, would you not? I mean, I raised a point a while back, and you answered one part of it, and it's very nice. Thank you. Would you not want a biopsy to plan your lymphadenectomy if it is an ICC? Would you not want to do some sort of lymph node sampling if it's an ICC, even if it's an intrahepatic ICC? Would you not want to do it? I want to know whether you would want to do it or not.
No, we will always do a complete lymphadenectomy if it's an intrahepatic cholangiocarcinoma. So
that establishes the need for a pre-op biopsy. Case closed.
No, only if you are in a dilemma, if your diagnosis is not clear. See, radiologically, there are pointers which suggest whether this disease is an intrahepatic cholangiocarcinoma or HCC. If you are in a no man's land, you are not sure, your radiologist is not helping you out, then yes, because intrahepatic cholangiocarcinoma is not a very common diagnosis that we made offhand. For in that scenario, yes, if there is any dilemma, I would rather err on the side of getting a biopsy rather than not biopsying it. Your thoughts, Abhishek?
I think to agree with Gagan, I think I would, because realistically you would get a resectable ICC in only about 10 to 15% of the cases. The rest of the times most of the cases will be unresectable. So obviously, if you're not contemplating resection, or you're considering in those 80% odd patients, you anyways will end up doing a biopsy. It's only in those rare instances where you find that it's a very resectable and early lesion where you can just take it out. Those conditions maybe no, but I would say that in about 80% of ICC, you would probably end up doing a biopsy for various reasons, either to give new adjuvant, or for transplantation, or for palliative care, etc., etc. So I think we all are saying the same thing, that in very selected patients we would not do a biopsy, but in most patients ultimately we would end up doing a biopsy for these tumors.
Right. I think Dr. Gagan is happier now. Right. So how do you assess resectability, Abhishek? Purely surgical question. You have answered quite a few here. So staging laparoscopy is a must for all these cases. Would you do it prior to any resection?
Yes.
Okay, fine. Secondly, would you use any method to augment FLR as you would do in HCC? Would you do a portal vein embolization in these cases? If
Yeah,
yes,
yeah.
In case if you do it, would you add? So if you're going to wait for about 6 to 8 weeks for these patients for your FLR to grow, like we would do it in a gallbladder cancer, we would like to give chemotherapy during this interim. So would you want to give chemotherapy during this interim period, or you would want to stage these patients prior to portal vein embolization and don't go ahead? So how would you proceed? I mean, it's more of a hypothetical. I don't know. I have never done a portal vein embolization for intrahepatic cholangio, and I don't know what your personal experience is. But for the discussion's sake, I think let's.
I think the indications of portal vein embolization would remain the same when you're resecting ICC versus resecting any other liver tumor. So I don't think there will be any difference. Regarding the role of neoadjuvant therapy, yes, especially for these borderline resectable tumors, I would definitely give them neoadjuvant therapy. If not with the intention of downstaging them, but definitely with the indication, with the intention of knowing the tumor biology. Because while generally that's a standard practice that we follow, that in an aggressive tumor, even when there's a aggressive HCC, we generally downstage them, or we give them upfront chemotherapy, even if not in the expectation of getting a dramatic result, but at least it tells us something about the biology. If on the chemotherapy your patient remains stable, the disease remains stable, then obviously you're dealing with a good biology. So I think
so my question was very specific. During that portal vein embolization waiting period, would you want your patient to have chemotherapy or not? Because we would do it for a CHG.
Yeah, if you're doing portal vein embolization, that means you are obviously dealing with an aggressive tumor.
Right?
Then yes, I would definitely.
Yeah. So have you ever stumbled upon any case or any report of ALPS for intrahepatic cholangio?
No, I did not. I don't have any experience with ALPS in these particular tumors. No, I do not.
Even I could not find any, so I thought I'll just ask you during this. Okay, what are your thoughts on anatomical versus non-anatomical resections?
Always anatomical resection.
Always anatomical.
I think for such an aggressive tumor, there's no point in doing half-hearted attempts.
Right. Perfect. So anatomical would always be better than a non-anatomical resection in this. Okay. Now, for a multifocal disease, do you consider them as a resectable cases? If yes, would you operate them upfront, or would you give them neoadjuvant chemotherapy as a rule of thumb?
I think the indication for resection would remain the same. Like if you can safely resect them with the adequate drained and supplied remnant. Whether it's multicentric or whatever it is, I would still go ahead with resection. The question about neoadjuvant or non-neoadjuvant, I think it's not that simple. I think it will depend on a lot of variables. That how risky do I think that the resection would be? If I feel that the patient it's going to be a straightforward resection, I do not expect too many problems. Patient has good performance status. There's a good remnant volume there. There's no portal hypertension there. So I would go for upfront resection. If any of these risk factors are present where I feel that there might be an early complication or early mortality morbidity following my resection because of various reasons, poor performance status, portal hypertension, etc., then in those cases, selectively I would give them neoadjuvant again to assess the biology, if not to downstage these tumors.
So problem with multifocal disease, Abhishek, is that literature says that the recurrence rates are very high.
I agree.
And these recurrences would happen in the remnant liver as well.
I agree with that literature, but then what is the other option these patients have?
So yes, so like the most of the times, what as a surgeons we get carried away is that the hubris of surgery, that okay, we have resected and patient's gonna be fine, but unfortunately these disease come back sooner than later, and then again many of times we don't end up helping these patients by resections. So I think there is more and more data coming up. It says that if you have a multifocal disease, I think it would be wiser to probably test the waters by selecting out good biology. You give them neoadjuvant, see the response, and probably select out good patients who probably would benefit better from our surgical, surgical techniques, and then just not become a mode of satisfying surgeons.
I completely agree with that. There's no doubt.
Okay, so last surgical thing that I want you to tell us is the extent of lymphadenectomy. Would it be an extensive lymphadenectomy like we do it for a gallbladder cancer, in which you do a complete lymphadenectomy along hepatoduodenal ligament and posterior pancreaticoduodenal nodes going up to celiac, or you would be more conservative in the lymphadenectomies of these patients?
No, I think I would definitely do a station 1 lymphadenectomy. Now, again, the lymphadenectomy, the pattern of lymphadenectomy would also depend in cholangiocarcinoma on where the anatomical site of the location is. Now, if you look at the lymphatic drainage of the liver, it's quite different from the left liver and the right liver. So if I'm doing a right hepatectomy, then my dissection would extend along the HDL, the hepatic artery, and also the retropancreatic. Versus if I'm doing a left-sided resection, in addition to the HDL, etc., I would also involve the lesser curvature nodes also. But yeah, I mean, I could not find any evidence to suggest that anything beyond the station 1 lymph nodes is indicated in managing these tumors. But like I said, it will also depend on the anatomical location of the primary disease.
Right, but good lymphadenectomy is always on the cards for intrahepatic cholangiocarcinoma.
Yes.
Right, great. Now, the role of neoadjuvant treatment. Now, most of these tumors are not resectable. Unfortunately, we could resect only 15 to 20% of these tumors. So there is a lot of role of downstaging nowadays in most of the cancers, and it's coming up more and more as the days are progressing. We hardly operate any upfront cases for esophagus. We hardly operate anything rectum in a de novo setting. Now, even for pan happening more and more. So the role of neoadjuvant therapy is there in IH, intrahepatic cholangios as well. So I would like to know, what are your thoughts on it? How are you going to, any personal experience or therapy, and what is your... Raajit, you there?
Yeah, I was not able to hear your question. So the question is what is written in the slide, right?
So neoadjuvant, what is your personal experience, your thoughts on it, and what is the standard regimen if you have to use it?
Yeah, so as of now, there is no standard regimen. There is no standard role of neoadjuvant, but we do give neoadjuvant that, as you have discussed, for certain for certain sets of patients to identify the biology and for certain large tumors. So there is no standard regimen. So whatever chemo we give is data from the other biliary malignancy, other extrahepatic malignancy we have. So the preferred regimen is a combination regimen in neoadjuvant setting, that is gemcitabine and cisplatin based regimen. There is also data of chemo RT, especially in data like Mayo data where they have given chemo RT. These are all retrospective studies. So it's basically a decision of the tumor board. So whether they want to give chemo or chemo RT, because as of now, there is no standard regimen, and we hardly see any intrahepatic cholangios here. So I've given it for 1 or 2 patients, but the biology is already bad, so that we know. So they were not able to undergo surgery. So one important thing regarding the biopsy is that, so because we also have certain molecular markers, like we have FGFR. So we have a FGFR inhibitor that is approved specially for cholangiocarcinoma. And we have other molecular inhibitors like IDH. We can also find BRCA mutation. So for all these testing, also the NGS testing, we also need a tissue. So tissue testing is really important if you are not planning for surgery.
So they would be for your stage 4 cancer, so you can do it for even for in a stage 3 or unresectable.
So if we are so intrahepatic cholangiocarcinoma, they rarely have distant mets. Whatever problem they have will be either they'll have vascular invasion or nodal invasion. So because of these reasons, this disease would not be resectable, or they'll have local recurrence. So for disease with such a bad biology, so there is no harm in doing all these tests upfront. So if you are planning neoadjuvant therapy, that means that this patient is not an ideal candidate for surgery upfront. So for that reason, there is no harm in doing NGS upfront.
Right. Dr. Gagan, do you have any personal experience of treating intrahepatic cholangios with radiation, either in neoadjuvant setting or later as a rescue therapy?
I do have very little experience. I do have experience, but it's very little. So the intrahepatic cholangio, the problem with intrahepatic cholangio is that we really can't do RT-CT in a conventional fractionated sense, concurrent CT-RT. So, most of the lesions are like SONs. So SBRT is what is to be done for an intrahepatic cholangio, unless of course the anatomy, because all these are loco-regional diseases. So unless of course there is any reason for us to consider otherwise, because every tumor can be different. But yeah, I would, in such a situation, I would prefer that you go for neoadjuvant. You take your call whether you are satisfied to surgically or not, whether you're still sure that it's not surgically operable. If it is not, then a good idea would be to consider SPRT or something like that, because practically you really can't do fractionated radiation within the liver. It's very difficult to be able to do it in the right way for 25 sittings. Probably end up causing RILD. That's my thought.
Right. So there is some upcoming role of loco-regional therapy here, the role of TACE and tear. Though these lesions are not as arterial enhancing as an HCC is, but there is definitely some role of TACE and tear here. So Sagar, what are your thoughts on that, and what would be an indication for TACE and tear as far as you are considered in these cases?
These vascular, yes, actually are not very vascular, but when we see a combined HCC-ICC variant, so TACE and tear can be useful in those patients.
So do you have any personal experience of these? I mean, I don't think we have done any here at Max Hospital, Saket, for such a case.
Not in ICC.
Right.
As of now, no.
Right. So I think we will go to the next here. That is the recurrence. I mean, the recurrence for these cholangiocarcinomas is a norm rather than an exception. And Dr. Gagan, you were asking in the chat box whether the recurrence rates of intrahepatic cholangiocarcinoma are more than the hilar ones or the periampullary ones. So periampullary, definitely the recurrence rates are low because we are able to usually get very good margins there. But the recurrence rates of perihilar cholangiocarcinoma are also very high. They're in the tune of around 40 to 60%. So I think this is the Achilles heels of the cholangiocarcinomas, be it intrahepatic or be it the perihilar. Now, I would want you to know from you, if you have a positive resection margin, how would you plan your radiation in such a case? I mean, like what Abhishek was mentioning, that liver is such a huge tumor and you have such a long and three-dimensional cut section there on the cut surface. How would you know like which part you need to irradiate and how would you target those? I mean, technically, is it different from other tumors or other anatomical areas?
Yes, of course. It is technically different from all other anatomical areas, but it pays to understand the anatomy well, and it pays a lot to discuss thoroughly with the surgeon, everything, and then with the radiologist, keep going back and forth. And then, so for extrahepatic cholangios, when we get a positive margin or something like that, and that's the bulk of experience, let me be candid there. We go back to the surgeon, we keep, going through the radiology, and then we localize the area which could be the problem. But the important thing first is to recognize the biliary tree in the new anatomy. So that's what we do. So we will finalize it. We will contour it, and we will give say for an extrahepatic, we will be giving a fractionated radiotherapy, because in a postoperative setting, all you have is the normal tissues. You can't really be doing SPRT in that place because you're not treating the tumor. You're actually treating the surrounding tissue. So that's one introduction to the answer to your question, because our topic here is intrahepatic cholangio. So I've answered the first part here. Now, for example, if there is an intrahepatic cholangio which you have resected and there is a positive margin, then it will be a different ball game. You were talking about anatomical resection. So I will have to go back and understand what has been resected and where is the margin. It will most likely be towards the hilum. The positive margin will most likely be towards the hilum due to the intraductal component or something like that. So I will make sure that I have localized that area, because otherwise the geographic miss would be disastrous. Then my second thought will be to go back to the radiologist to try and understand that, okay, this was positive, how deep the intraductal component would probably be, so that we don't miss any gross disease which was left unexplored. That will be part 2. The rest will be quite easy, because then I will have to take the usual suspects of posterior pancreatic or duodenal lymph nodes and so on and so forth, those regional lymph nodes, and I will create a 3-dimensional volume which I will irradiate in a fractionated way with concurrent chemotherapy, keeping in mind the movement of the liver. The 4-dimensional CT we will do in this process. I hope I've answered your question.
Right. So in this case, how would rather be different from an intrahepatic cholangio would be different from an hilar is that you can have resection margin positive at any place at the cut surface of the liver, not necessarily at the hilum. That would be an hilar cholangio, where you would get an hilar resection margin, and it will be easier for you to target that. But here you can have a positive margin anywhere along the cut surface of the liver, and it will be very difficult for us to pinpoint because you have such a big tumor, and it is sitting at such a lengthy cut surface. So it will become very tedious for even surgeon to say, okay, this is the likely positive margin. He will also not know where he erred on the side of towards the tumor. So that would be one tricky thing.
So to answer this, okay, sorry, Abhishek, please go ahead.
I think what we have done is in a couple of cases when obviously the surgeons know that where is the likelihood of a positive margin. So we've come out, we put some clips and all in that area. We put some large clips and all. But to be honest, post-operatively, it's not easy, those clips, because when you're doing a liver resection, there are going to be clips everywhere. So we do put some special clips, large clips, etc. But post-operatively planning still, at least in our experience of 2 cases that we've resected and we put clips, and then we asked our radiation oncologist to give us radiation there. I don't know, but it's not been that simple. I mean, there is a practical difficulty there.
Dr. Asit, the question that you asked me, if Dr. Abhishek will put a clip, of course, that will help. If you guys will put a clip, that will certainly be of big help, because even if there are many clips, it does pay. The surgeon sits down and it takes 5 minutes, but then they orient themselves and they say, this must be the clip, or these 2 or 3 might be the clips. So we can always go back and figure it out. So to answer your question which you posed to me, that okay, fine, if it is an intrahepatic large one and we are not very sure which the margin is, then of course the point is to be a little bit more liberal in the edges. Again, I will have to go back and ask you that how was the anatomical resection performed, and maybe go a little bit deeper on that, so that I can at least ascertain what surface I have to irradiate and how I have to irradiate it. But I do feel that this will not be a case in every. This will not be the situation in every case. There will be situations where the positive margins will be left inadvertently of the intraductal component and so on and so forth for an intrahepatic cholangio, wherein what I explained previously, that the margin would be more towards the hilum. I didn't mean the hilar cholangio, I meant more towards the hilum. Those are the likely areas where margins could be positive. I'm not speaking from huge amount of experience. As I said, I will be earnest. But this is my going to be my strategy, and we will evolve on it when a case like that comes.
Right. So Raajit, what would be the role of chemotherapy in adjuvant setting? I mean, if you extrapolate it from other cholangios and also gallbladder,
so we don't have much data. We have a guideline which can help us. We have ASCO 2019 guidelines, so that probably also answers your chemoradiation question. So according to this, for R2 resection, there is definitely a role of radiation in intrahepatic cholangiocarcinoma. For R1, they don't usually recommend radiation. So for that, chemotherapy remains the option because of all those difficulties we have in planning and giving radiation. So the chemotherapy, we have 2 or 3 choices based on the extra hepatic or biliary malignancies. Either we can give single agent CAPE as per the BILCAP data, or we can give GEMSIS as adjuvant chemo. If we are planning radiation, then we can give 5FU along with radiation, or we can give KPART. Plus, we also have to consolidate with systemic chemotherapy.
And that duration would be how long? Typically 6 months?
So duration would be 6 months.
6 months, right. So it will be in tune with any other cholangio or a gallbladder like scenarios,
Yeah.
right?
Yeah.
Right, perfect. Now there will be a very special circumstance that you can have a liver only recurrence. You have a future liver remnant and there is a recurrence in that. So that could be potentially resectable. So Dr. Abhishek, would you be keen to resect these lesions?
I think again it will depend on what I think about the tumor biology. I mean, if it is resectable, low risk recurrence, definitely resect. But if obviously the recurrence is happening within 1 month of my doing the primary resection, I know it's a bad tumor, and then probably I would just offer this patient, other treatment modalities.
Yeah, so I mean, obviously, if you take in account of those things, that how is your disease-free interval and how is the biology. But if you have a recurrence
Definitely,
in
yeah.
a future liver remnant, would you be
Definitely.
keen to resect these?
Yeah, resectable, yes.
Right. Sagar, what is the role of RFA in such a lesion, and how confident are you of RFAing these tumors? And what would be your cutoff size for RFA for a recurrence or a small lesion in a intrahepatic cholangiocarcinoma?
So RFA results are good when lesions are less than 3 centimeters, but we have done RFAs for lesions more than 3 centimeters also, but never for lesions which are more than 5 centimeters. 3 to 5 centimeters is the basic lesion size what we get, but best results are again in which the lesion is less than 3 centimeters in size. Also, no vascular invasion. If the lesion has no vascular invasion of any sort, then the results are obviously very good.
So, what is your
And a
take on microwave
follow-up.
ablation versus RFA? So, what would you prefer, microwave versus RFA, and where would you choose one over the other?
Sir, I haven't done microwave ablation for ICC or for HCC. We have done RFAs only, and the results were pretty good. We have done 3 cases in the last 6 months, and we got like no peripheral enhancement after follow-up CT on 1 month. So actually, complete, yeah.
So, in a nutshell, I can say, I mean, the indications and the technique would almost be same as you would use for an HCC.
Yes, sir. Yes.
Right. So, if you have a vascular structure close by, so you would rather prefer a microwave over a RFA. So, yes. Can we safely conclude that?
Yes.
Yeah. So, Dr. Gagan, would you be happy to radiate this patient with a radical intent? I mean, if there is a small recurrence in a future liver remnant, and if it is close to some anatomical structure, and Abhishek says, no, I don't want to resect it, would you be happy to give him extra EBRT to take care of such a lesion?
Yes, that would be a good idea, but SBRT. Because,
SBRT, yeah. So, what would be the size criteria here, and how would you choose that patient?
Size criteria, there are no fixed criteria. There is volume criteria in SBRT, as in I should be able to spare in a non-cirrhotic liver about 700 cc of 12 Gray. And then there are more criteria which we use now, which are more of a mathematical function of integration. It's called, it's basically an equivalent of liver which is getting irradiated. So we have all those things in the department. So to answer your question, that there is definitely going to be the largest size which we can irradiate, wherein when we irradiate it, we will not be able to spare the liver to the to a viable volume, and therefore we should not be irradiating it. So, but I don't imagine something like a positive margin or a small recurrence or something like that will be limiting it. But if there has to be one empirical number at which we should stop, it should be 6 or 7 centimeters. But then up to 10 centimeters one can irradiate, and even if some little bit results come in HCC, they are always beneficial in improving the life. But that's HCC, not ICC.
Right. And I think you have already dealt with this, Abhishek. You want to touch upon it again? How would you choose a patient for transplant in intrahepatic cholangiocarcinoma? It's a fairly new thing, and people are exploring this more and more now. So,
well, in this, to be honest, in this day and age, I mean, if you have a pre-op diagnosis of intrahepatic cholangiocarcinoma, then definitely no to transplant. When you have a like I said, the diagnostic dilemma that sometimes you do end up transplanting these patients, but I think as of now, we don't have enough evidence to say that upfront transplant for intrahepatic cholangiocarcinoma. No, I think that will be stretching the boundaries a bit too far.
Dr. Asit, can I ask a question?
Yeah, sure, please, why not?
Dr. Abhishek, would you transplant a multifocal ICC? Would that not be a good indication?
Multifocal ICC for transplantation? No, I don't think I would transplant a unifocal ICC also if I'm quite convinced that it's a intrahepatic cholangiocarcinoma.
But if it's multifocal, you won't be able to address it, no, with a localized resection. Would there be
yeah, I know, but it's better to send the patient for some other modality rather than doing a transplant and then patient comes back with the recurrence, even before he's discharged from the hospital.
So you would biologically select the patient. Suppose the patient is biologically selected and there is response. Would then this patient be a good candidate for transplant? Because
well, I think we should be careful about venturing for transplant in these patients. I think only if you're part of a clinical trial or something, only then I would attempt a upfront transplant for intrahepatic cholangiocarcinoma, or until we have more evidence coming in. Because like I said, that the 3 patients that we encountered, we have done transplants, but those have been inadvertent transplants. We thought that we are transplanting for HCC. However, the biopsy has turned out to be mixed variants. But if upfront before the transplant, I'm convinced that it's ICC, then no, I would not venture into transplant unless I'm part of a clinical trial or something.
Right. I think that to my mind, that covers all the aspects of intrahepatic cholangio. If anybody wishes to add anything, Dr. Gagan, Abhishek, Raajit, do you think there is anything from your side? If you want to discuss further, I'll be happy to have any more discussions and questions.
So, Dr. Raajit, what is that FGFR inhibitor that is approved specifically for cholangio? Which one is that?
I think it is called as pemigatinib. I'm not sure how to pronounce it, but it's similar to like pemigatinib. Yeah.
If you are not sure how to pronounce it, then think about us lesser mortals. हम क्या करेंगे भाई?
So once I start writing it, then I'll definitely know how to pronounce the drug.
Yeah, I know. That's the trick. You have to write it. Okay.
I think I should apologize to your radiologist, Dr. Sagar, because I think I covered your area also. The topic I thought was I think what was the topic? It was approach and management. So I thought it would be not fair that if I don't cover radiology also in the approach. So apologies for that, for kind of barging into your territory.
2 people covering it made people like us understand it better. So it's good actually.
I know. Right. So, I mean, it was a wonderful session. I learned a lot. I don't know about others, but it was very good and eye-opener for me. And thank you, Abhishek, for sparing time out of your busy schedule. Thank you, Dr. Gagan. It was really nice listening to your thoughts. Thank you, Sagar, and thank you, Raajit. It was so good to see you after so long. I think this was the first meeting after I left Dharamshila. So I think we have these meetings every fortnightly, and we would definitely invite you again. We will trouble you again to take time out of your busy schedule. And thank you so much, guys. Thank you. Thanks.
Good night.
Thank you.
Bye-bye.